How have macular edema treatments changed from laser to injections? Imagine a time when laser beams were the main tool to fight swelling in the eye. That was the early approach for treating macular edema, especially in people with diabetic eye disease. Laser photocoagulation involved shining a focused laser onto the retina to seal leaking blood vessels. This helped reduce fluid buildup in the central part of the retina, known as the macula. Studies showed that laser could cut the risk of losing moderate vision by about half over 3 years. It worked by causing tiny burns that changed the retina's biochemistry, improving oxygen flow and reducing blood vessel leakage. To make laser treatment safer, doctors developed micropulse laser therapy, which uses short bursts of laser to minimize damage while still helping the eye. But laser therapy had its limits. It mostly stabilized vision rather than making it better. Also, it could cause some retinal damage, and it was less effective when the fluid affected the very center of the retina, where vision is sharpest. As a result, researchers looked for better options. That's where injections into the eye came into play. The breakthrough came with drugs that target a protein called vascular endothelial growth factor, or VEGF. These drugs include ranibizumab, bevacizumab, and aflibercept. They work by blocking VEGF, which promotes abnormal blood vessel growth and leakage. By stopping VEGF, these injections reduce swelling, inflammation, and fluid leakage in the retina. Corticosteroid injections also became part of the treatment arsenal because they help calm inflammation and decrease blood vessel permeability. These medications are injected directly into the vitreous, the gel-like substance inside the eye, allowing high local concentrations and fewer side effects elsewhere in the body. Clinical studies and real-world experience have shown that anti-VEGF injections often lead to better vision improvement than laser alone, especially when the swelling involves the center of the retina. Patients receiving these injections tend to see clearer and sharper vision over time. While laser still has a role, especially for certain types of edema that are not in the central part of the retina, injections have become the main first-line treatment. Sometimes, doctors combine both approaches to get the best results, especially if the edema is in different parts of the retina or if the response to injections is not ideal. In summary, the shift from laser to injections reflects our growing understanding of the disease and advances in medication. Laser remains useful in some cases but has largely been replaced by injections that offer better chances of improving vision and controlling the swelling. Treatment plans are personalized, often combining both methods based on the location and severity of the edema and how the patient responds. Current guidelines from eye health authorities recommend anti-VEGF and corticosteroid injections as the primary options, with laser as a helpful supplement. Always consult with a retina specialist to find the best approach for your specific condition.